So, Paul Sugarmaker, it's of course a great honor for us to have you for this interview for our diploma in France. And we reserved to you probably one of the most difficult, but also the most important topic on peritoneal surface malignancy, how to teach the cytoreduction and IPEC. So, what would you recommend? What would be your most important advice for one colorectal surgeon who wants to learn and begin cytoreductive surgery and IPEC into his center?
First of all, it's extremely important that this one surgeon have a commitment, a dedication to helping us solve the problem of peritoneal metastases and local recurrence in patients with colorectal malignancy. It is still a huge problem. Patients are failing regionally, and this person has to realize that what we're now doing in terms of either laparoscopic or open resection is not perfect. Patients are still failing, and in some instances failing miserably. So he needs the commitment and the dedication. I would suggest that a first step would be to attend one of the workshops that are now available with live surgery, with animal laboratory experience, and I would say that's a very important place to start. But that's not enough. Traditionally, surgery is only taught well shoulder to shoulder. So this person needs to affiliate himself with a experienced center and participate in a large number. We're estimating that about 20 times he needs to scrub in. With scrub in, that means you need to be present in the operating room. You need to get your hands into the operative space, and in at least 20 instances go through with an experienced mentor the cytoreductive process, and also in some of those patients you need to be present preoperatively and then for a prolonged period postoperatively in order to appreciate the complexity of cytoreductive surgery combined with HIPEC. So yes, a commitment, attend a course, and then find a mentor to work with over, what is it going to take? It's going to take a year to maybe even more to say, okay, I'm now comfortable to perform CRS and HIPEC on my own.
Okay. And for the specific use of HIPEC, what is the best way to learn how to perform HIPEC? Which HIPEC do you have to use?
Yeah, that's a good question. I don't think that all HIPECs are the same. Now, you know, one of the things, once you establish a phenomenon, CRS and HIPEC, then after you believe that it really works, you begin to take apart the various components and what is going to be essential for the long run and what is not. Well, we know that this cytoreductive surgery is crucial, and it needs to be done perfectly. And then how do you learn to do the HIPEC, or what is the best HIPEC? And you know what? I don't think we have an answer to that problem. I think it's very healthy that right now there are numerous different ways of performing HIPEC. There's different drugs. There's at least 4 different methodologies for performing HIPEC. And I think that what one needs to do is carefully and consistently use one method of HIPEC, get used to it, get used to the drugs, what the complications of, we have the 2 major groups, the oxaliplatinum 5-FU, and then we have the mitomycin C. They have quite different toxicities and complications. So I would advise this person to adopt a particular treatment plan, get used to it, and learn to use that particular type of HIPEC. Of course, if he wants to come and work with me, I'm going to teach him the open technique with the laminar flow protection of the environment. And we think that's a very good both mechanical and chemical cleansing of the peritoneal space. But it's certainly not the only way to go.
And do you think that now each country should integrate teaching of cytoreductive surgery and HIPEC into the general formation of the surgical oncologist, the surgeon, or general surgeon?
Well, certainly for a surgical oncology teaching program, I think that experience in cytoreductive surgery and in the selection of patients for HIPEC is absolutely crucial. And in the United States now, in a majority of the surgical oncology training programs, the individual is trained at least in the initial phase for cytoreductive surgery and HIPEC. And I have to say that most of the young men and women coming out of the training programs want to be experts in CRS and HIPEC, because in order to get a job in the United States at this point in time, a familiarity and a certain level of confidence in using cytoreductive surgery and HIPEC is necessary in order to get a good job. Okay, so right now it's not only a good idea from a patient care perspective, but the institutions that are hiring these young surgical oncologists, they want them to know how to perform CRS and HIPEC.
So I think we did the big step.
Yes.
Yeah.
Yes.
So many thanks, Paul, for
okay,
some
it's
minutes.
been a pleasure. Yeah.
Thank you.
Thank you.